So hi and welcome to this live session. After a lot of days, we are meeting live, and this is one of the very important topics for I think every resident from first year to final year. This is a topic that you'll encounter a lot. One of the most common head CTs that are indicated are usually trauma cases. If you work in a hospital which has trauma cases, then these will be the bulk of the head CTs that we get to report. So this becomes a very, very important topic to understand. And not just the basic radiology, we are also going to be talking a lot. So we're going to start off from the very basics and build it up towards the end. And, there's a special a surprise for you where we'll be having a neurosurgeon who's going to talk about, what they actually want from the reporting, what are the important measurements which are needed, so the specifics from a clinician's point of view is also something that we'll discuss. And yes, it's Dr. Ravi, so in-house expert, so didn't really have to look very far for a neurosurgeon, so that was the good part. So this is what we'll keep doing, right? So with every clinical case discussion, we'll try and have a clinical point of view as well, because that's what we are training to be. That's what the whole idea is, for us to be very, very aware clinically of what is going to happen, what is the implication of every single measurement that I give in my report, what is the implication of every single statement that I write. And we want to be aware of the other side as well. We don't just want to report, for the sake of it. So that's what we are trying to do here as far as the learning is concerned, and that's what we are doing in this important topic of head trauma as well. All right, so hope you are all doing well. Keep answering simultaneously. Let's keep it interactive, and let's begin. And then towards the end, maybe we can chat a bit about other things that you may want to share about how residency is going, any other topics that you want to request for, because I'm going to be putting up a few recorded lectures after the 15-day schedule is over. So any new topics that you want to ask for, we can have some interaction towards the end about that as well. All right, so let's first begin with head trauma and the resources which I have used, and these are really good reads for a resident. So I'm also gonna put these PDFs on the Telegram group, and from now on, another thing which we'll add on to the app is in the notes section. You already see the PDF of the class. If there are any supplementary reads, which I want you to do, for example, you had a class on pediatric liver masses, so the radiographics article that Dr. Siddhi was referring to, we will put that in the notes only. We'll put that PDF there only, so it becomes very easy for you to access the supplementary reading material at the same time, just. And what I would advise you as a senior, if you're short on time, already we have referred to these when we are teaching you, so you don't have to read it, line by line very slowly. Give it a very quick read. What you can actually do is go through the images, radiographics, obviously, the name tells you it's about the images. So see the images at least, how they have been described. Learn from these, so at the beginning itself, when you make it a habit to know, read the descriptions very well, that's the language that you will learn. And it's a new language. The reporting language is a new language that you're learning in the 3 years, and then it comes to you pretty naturally, it will. So make it a point of seeing images in every article you come across, and read what is the annotation given below it. So that's the bare minimum you can do if you can't read the complete articles. So I'll keep putting these PDFs there only. The option to annotate it is not there. That's not the tech which we have. So you can't annotate it, but you will find the annotated PDFs only. Apart from that, if you want to annotate them in your iPad, I'll also share these on Telegram, these radiographic articles, so that you can have them saved. The only thing is, in the end, you end up having a lot of these articles, and then you don't know if you've not organized them from the word get-go. So the app will kind of organize them for you. So that's the additional advantage, right? Okay, so let's begin then. So these are the 3 things that I want you to read. These would be good to read, even though I've included. So obviously, Osborne is as I said, our Bible for neuroradiology. This is what the base is going to be. 2 very good articles, one on traumatic brain injury imaging patterns from radiographics, and one is on herniation. So this is both what I have referenced in this class class as well. All right. As far as workstation case discussions, will keep coming up. Right now, trying to cover more theory. Case discussions, will do them closer to the exam, so don't want to start off with them. But workstation and reading cases, I'm going to be recording a few sessions, about basics, since a lot of you are first year. So how to read a brain CT, chest CT, abdomen CT. So that's what's going to come up by next week latest, right? So that's what is next on my plan. Case discussions, I'm going to save them. I want to cover some more ground of teaching first, so that you are equipped, and then we can discuss and interact and have more case discussions, right? That's the plan, Nishta. Okay, right. So now let's get on to head injury per se. So how do we classify it? So, clinically traumatic brain injuries, usually in trauma centers, this is what we will do on the basis of the Glasgow Coma score. So, the maximum score is 15, right? So, 13 to 15 is a mild TBI, mild traumatic brain injury. 9 to 12 is moderate. And what you need to remember is anything less than 8. That's the number. Anything less than 8 is severe, and it also becomes an indication of elective intubation of the patient, right? So, most of these patients are going to be intubated who are GCS less than 8 or severe traumatic brain injury. Another classification as far as the pathology is concerned is what is a primary brain injury. So what we include here are scalp injuries, skull injuries. So these are because of the result of the impact. That is what is the meaning of a primary brain injury. This happened because of the impact. Extra-axial hematomas, parenchymal injuries, and vascular injuries. So extra-axial hematomas, we will be reading them under 3 heads, as I'm sure you all know. Outside the dura, we call them extradural hematoma. SDH, subdural hematoma between dura and arachnoid, between arachnoid and pia mater in the cisterns. So this is subarachnoid hemorrhage. Parenchymal injuries, mainly 2 headings we are going to be covering them in. One are your contusions, which may be hemorrhagic or non-hemorrhagic, and second is your axonal injury, diffuse axonal injury. As far as vascular injury is concerned, the extreme form of diffuse axonal injury, where you can have microvasculature bleed, that's called as diffuse vascular injury. That's a primary vascular injury. Apart from that, you can have vascular injury which are resulting because of the fractures, right? So when you have fracture passing through a venous sinus or a carotid canal or any foramina like foramen transversarium, those vascular injuries are also called as primary vascular injuries. The secondary brain injuries are a result of the primary vascular injury. So herniation, let's say you have an EDH because of the pressure, you are having secondary herniation. That's a secondary brain injury. Cerebral edema, ischemia, vascular injury. So vascular injury, as you can see, comes in both. So if you have compression, let's say that there is an EDH which resulted in a subfalcine herniation, which resulted in a ACA infarct. So that's a secondary vascular injury. So this is how you have to classify. Anytime you get a long answer question on head trauma, this is what you start off with. If you start off with this, the examiner will know that you know the rest of it, right? So you always have to set the tone right in everything related to the exams. That is very important. So this is what you remember as a paragraph. So sorry for that. So that is what you remember as a so primary and secondary, this is what we classify the head trauma injuries as. Now when we talk about the imaging modalities here, so what are the modalities that we use as far as head trauma is concerned? So the workhorse here is a non-contrast CT scan, right? So it's NCCT, which is the most important primary study. So any patient with suspected head trauma will only undergo NCCT. There is absolutely no role of any radiography in today's age and time. What are the indications? Very, very important. So the indications, any patient who has a GCS less than 13. So anybody with a moderate or severe head injury is going to get a non-contrast CT. Any patient who is a child under 2 years of age with head trauma will get a head CT. Then you need to be aware of these 2 criteria here. So first is the New Orleans criteria, and then we have the Canadian head CT rule. you don't have to memorize them per se, but you just need to be aware of the names, because you do get asked about the names here. It depends on what you follow at your centers, so usually it is the Canadian head CT rule which is more widely followed, but more or less both have the same concept here, that if the GCS is 15 and you have any of these, so if you have headache, vomiting, anything which goes points towards raised intracranial pressure, extremes of ages more than 60 years, intoxication, memory deficits, visible trauma about the clavicles, or seizures. So, any focal neurological deficit is there, indication of CT is there. Then, what does the Canadian HCT rule add here? So, they say if GCS is 13 to 15 and witnessed loss of consciousness, amnesia, or confusion. So, basically, they are saying if there is any focal neurological deficit in a mild head injury, then we should do it. Any GCS which is less than 15 at 2 hours. So, delayed also at 2 hours if it is this, if it is lesser than 15, indication suspected open or depressed skull fracture, skull base fracture, two or more. So the only difference here is New Orleans doesn't mention how many vomiting episodes. Canadian HCT says two or more. Here the age is 60. Here it is 65 years. Antegrade amnesia more than equal to 30 minutes, or any dangerous mechanism. So basically this is fine in theory, but ultimately we'll also hear from the neurosurgeon, about what they actually follow. And what you will actually hear is it's a lot based on instincts, and it's a lot based on how severe clinically the patient looks, how severe the mechanism of the injury is. So this is what you want to remember here. Neither one mentions less than 2, because that is something which is a given, so less than 13 and under 2, everybody gets it, so these are for minor head injury. The moment it is less than 2 years, it doesn't come under this heading. तो वो तो पहले ही clear हो गया that इनका करना ही है. Understanding? So these CT are already done. As far as 15 GCS or 13 to 15 GCS is concerned, you need to see for these dangerous mechanism, or these red flags basically. So that is what you got to learn here. And very important, again, something that we get a clinical point of view from here is that when is a repeat CT actually indicated? You must be getting a lot of requisitions, and the radiographer ends up doing them. Obviously, every time it is requested for, but you need to know what is the actual indication. So, if the GCS is not improving, or there is some deterioration, as simple as that. If the patient is not improving or deteriorating, you would want to do a repeat CT. And usually in trauma centers, you will see in most patients with hemorrhagic contusions, they would be followed up on CT, 24 hourly, because there is an increase that is expected in the edema at around 12 to 24 hours, right? So that is what is usually done. Talking about other modalities. So CT, obviously, we now know who gets it. That's the primary workhorse. When do we do a CT angiography? Because this is something you need to be aware of. You don't want to send the patient and then call the patient again. This is something which is very important, that if you are the radiologist who's posted there, if you've seen the CT on the console, then that's the moment you decide that I need to give contrast. You discuss with the neurosurgeon, you give a call, and you decide that I should give the contrast right here, right now, and not send the patient back. And then the neurosurgeon will request that, okay, I want to do a CT angio. No, you just discuss then and there, give contrast in the same setting. So, what are those settings in which you want to do a CT angiography? One, if there is a penetrating neck injury, this is one case where it will already be requested for. If we will be talking about neck trauma as well, differently, separately, but if there is, a suspected hard sign for a vascular trauma in the neck, it will be requested for upfront. But what do you see in the CT that warrants a CT angiography? One would be a foramen transversarium fracture on a C-spine CT, or a facet subluxation when you want to look for the vertebral artery trauma. Skull base fracture that traverses the carotid canal, or any location of the dural venous sinus. Like, look at this case here. So you can see how at the spheno-occipital synchondrosis, yeah, this is one of the very common sites where a diastasis happens. Now, what is a diastasis? A diastatic fracture is where there is a sutural separation. Okay, so this is what we are seeing here. There is a sutural separation which has happened, and it courses through the carotid canal. As you can see, it courses through the foramen lacerum, through the carotid canal. That's what I'm showing with the pointer. And in addition, there is also a fracture here. This is the location of the transverse sinus, right? So when you see that there are fractures, there is diastatic fracture and there's a fracture, linear fracture, which is coursing through the vascular territory, this is when you want to give contrast. So you can see how the carotid artery is seen here. You can see that the transverse sinus is intact. So even though there is no vascular injury here, but you want to do a CT angio to rule it out. Okay, I will repeat the diastatic fracture part when we get to fractures. Okay, so basically this is the sphenoid, body of sphenoid. This is the clivus. So this point is the spheno-occipital synchondrosis. So this is one of the sutures which fuses very late. It fuses as late as adolescence, 17, 18 years. So this is one of the common sites for sutural diastasis. Yeah, sutural diastasis or diastatic fracture where the sutures open up. Okay, so this is what you want to know here. Fine. Yeah, I will point with laser from now on. So this is one of the indications of CT angio. Anytime there is a facial fracture or LIFO 2 or 3 we want to do, but again, facial fractures, maxillofacial injuries, we'll talk about separately. If you have a patient with diffuse axonal injury with a very low GCS that is less than 6, you again want to do a CT angio because there's very high association with vascular injuries and near hanging injuries. Again, we will cover in neck trauma. So this is what you want to do. Yeah, we will definitely talk about vessels, vascular anatomy, paranasal sinus anatomy, dural venous sinus anatomy, everything in anatomy we'll keep covering. Let's just do the clinical part here and then basics also will keep coming on simultaneously. All right. Talking about MRI, what are the niche indications when after CT you want to do an MRI? So one is when you have a suspected diffuse axonal injury. So this is the only condition in primary head injury where you would want to do MRI because the CT may underestimate these microbleeds. And this is something that we all study for NEET PG entrance as well, that, this one line that CT is the investigation of choice for head trauma, except DI, where MRI is better. Now, obviously, we know much better than that one line. The diffuse axonal injury, we are going to have small microbleeds, and that is where we want to do MRI to pick it up, and I'll talk more about it. Any case of suspected non-accidental injury or child abuse, we want to do MRI because there can be multifocal bleeds. There can be different ages of bleed, and we will see as we go along that NCCT is best for acute bleed because less than 24 hours or that is hyperacute. 1 to 3 days is acute. So basically till 3 days we are gonna have hyper density on the CT, but following that I'll also talk about this. The HU keeps dropping, so it becomes isodense, then it becomes hypodense. So beyond that, the moment it becomes isodense, we may miss injuries, and that's why MRI becomes better then. So more than 24 to 48 hours, more than around 2 days, MRI becomes better than the CT, right? So this is what we are seeing here as well. So look at this on the MRI. Can somebody tell me where is the hemorrhage? If you can pick it up. Okay, I think my camera will work now. So if you can just look at this MRI in the meanwhile and tell me right side, left side, what do you think is the finding here? SDH, right side, left side? Left. Most of you are saying left. Okay. So you are seeing this, I guess. Anybody thinks there is something on the right side as well? Yeah, so what you are actually having is bilateral SDH, isn't it? So see here with the laser pointer, there is this one hematoma and then there is this one hematoma. So if I ask you what is the age of this hemorrhage, Do you know how to age hematomas on MRI? Do you know any mnemonic to remember this? Whether it is hyperacute, acute, subacute. So I'll teach you one. Okay. So this is a nice a poem that we are going to learn now, and we'll always remember them. So what you have to do is you have the T1 and you have the T2. Yeah. So you guys know. So what we have, few of you know. So what you have to remember is I bleed, I die, bleed, die, bleed, bleed, die, die. That's the poem we remember. What is the meaning of that? So I bleed. Yeah. I die. I bleed, I die. Then what do you say? You say bleed, die, bleed, bleed, die, die. This is what we have to remember here, and this is how you're going to remember the signal intensity of hematomas at different time points. Okay, so I stands for intermediate signal intensity, B stands for bright, D stands for dark. Whenever I say any signal intensity, we compare it with the brain parenchyma. We compare it with the cortex, right? That's what we are comparing it with. So if it is iso or intermediate, I call it I. If it is whiter than that, I call it B. If it is hypo to it, I call it D. So now what does this mean? So during what time point? So hyperacute hematomas, which are less than 24 hours, they are going to be iso intense or intermediate on T1 and bright on T2. That is the meaning. Acute meaning 1 to 3 days. So less than 48 to 72 hours is acute. Then we have early subacute and we have late subacute. Early subacute meaning 3 to 7 days. Later subacute means 7 to 14 days. And chronic means more than 14 days. So with this, you can remember the signal intensity at different time points. So let's compare here. What you see on the right side is hyper intense. So this is bright. And what you see on the T2 weighted image here is that it is almost iso intense, slightly hypo intense. So right sided, what it matches with is an early subacute sort of a SDH. And on the left side, you can see it's almost intermediate to iso intense and it is bright here on T2. So it matches somewhere with hyper acute. So whenever you see different ages of bleeding, it's something where you suspect non-accidental injury, or you have to rule out why there are different ages of bleeding. So this is how you are going to be uh, saying the ages of the bleed. I hope this is clear to all of you. So this is the poem that you remember and take away with you for life, for staging the age of MRI. So the bottom line here is that MRI is useful for older injuries. How to tell if it's EDH versus SDH? So that's what we are going to discuss, right? That's something which is very important that we are going to get to once we discuss the modalities. Okay, so this is what you want to remember here. Fine. Right. Moving on to the next thing. So imaging modalities, coming on to DSA. So now when we talk about the DSA here, the indications would be when you have proven that there is some sort of a vascular injury. So first would be pseudoaneurysm. So SAH if you are seeing, and we'll talk about it as well. Aneurysmal SAH is what we want to rule out. If you have seen an aneurysmal SAH on DSA, that's what we do. CCF, what is CCF? So carotico-cavernous fistula. When would you suspect a CCF? So this is one of the spotters that you keep getting, right? So what do you see on this CCT here? How would you report this as? I'm seeing that on the right side, not an AVM. Look at this CT. What is your finding? Anybody can tell me? This is one of the spotters that you frequently get. Look at the two things that I have made circles. Kya dikh raha hai? Yes. So this is the superior ophthalmic vein, which is looking like a hockey stick. Yeah. So this hockey stick structure is the superior ophthalmic vein. Can you tell me where the superior ophthalmic vein drains? Again, on the DSA, this is the superior ophthalmic vein. Correct. It drains in the cavernous sinus. And can you see how the cavernous sinus is really bulky on the right side on the CCT? So what we are seeing here is on the DSA, in the ICA run on the right side, we can see how the cavernous sinus is opacified, and you can see that the superior ophthalmic vein, a tributary of the cavernous sinus, is also filling up with blood because there is a communication. There is a fistulous communication between carotid artery and the cavernous sinus. Yes, there is Barrow's classification for it, where you have multiple types of what kind of a leak there is. We'll talk about that when we go to IR. But basically, that is one of the indications for DSA when you're seeing a suspected CCF on CCT, or any other vascular injuries have been suspected, like we saw, the indications for CT angio here. All right, so this is what you have to remember here. This is the most important, so I want you all to take a screenshot here and save this for any time that you are reporting a CT head for a trauma case. So this is how your approach has to be built. Remember how we studied the approach for bone tumors, how we studied the approach for degenerative spine. This is how case to case, I want to give you these modules, these checklists, so that when you are reporting in practice, in residency, you go back to this and you do a systematic analysis. So first, you always, something that we tend to miss is the scout, right? So the scout image, I want you to look at it because it will give you a view of the C spine. It is something, thank you, it is something that you will not see, otherwise. So C spine you want to also see in every case of a CT head. Even if it has not been requested for, you want to see this. Jaw and facial injuries, a lot of times they are not going to be included in the brain CT that are requested for, but the scout will give you this bird's eye view of what is happening to the adjacent structures like the C spine, jaw, facial injuries, if any, and foreign body. In one look, you will be able to look at any metallic foreign body if it's there somewhere, right? So scout is very good for these three. Just give a quick glance and rule other things out. Then when we talk about the CT, the brain windows always start from outside in. Chest X-ray also we discuss something similar, inside out. Now we're going from outside to inside. What exactly is the scout? So scout is the tomo view that you take, right? Should have added an image. Yeah, I think scout now, the tomo that we take, right? So when we talk about the CT brain windows, you start from outside in. So what you're gonna start off with is the scalp. Okay, so we look at the scalp first. Look at the bones on the skull fractures. So now in bones, we are going to have bone window. Yeah, we all know bone window, yes. And we have bone recons, right? I think you are aware of both of these terms. So whenever you have the CT recons, I hope you know how a CT of the brain is acquired. A CT of the brain is acquired at an angle so that we can save the radiation to the eye. So the gantry is always angled. I hope you have seen that. Even if you are first years, I think you should just see when a CT is being acquired of the head, just see it once. It is usually angled such that you will not have radiation to the eye. So angled 5 mm sections are acquired for a head CT usually. Then what we do are we make thin recons. So usually 2.5 mm recons are made in most CTs, in most hospitals. Sometimes if you want thinner recons, if you want to look, you're suspecting a skull base fracture, you can request the radiographer that I want 1.5 mm thin recons. Okay, so this is something you should know कि 5 mm में हम acquire करते, we see 2.5 mm recons, but you can also get 1.5 mm thin recons if requested. In addition to the brain window that you will have, the soft tissue window, you will also get bone recons जो higher hard होते हैं, right? We'll have some basic discussion on this also. What are different recons? Reconstructions is what I mean by recons. So bone reconstruction is much better to evaluate fracture than just that simple bone window that you click to make the bone window. So always make this a habit, right? So learning all this from the first year is a really good place to, inculcate good habits of reading. So start with the bone recons. Request your radiographer that this is what I want. It hardly takes 1 second to make them. So bone recons are better for evaluating skull fracture. That's the message. So we are coming inside. Scalp देख लिया, skull देख लिया. Now look for any extra-axial hematoma outside the brain, which could be EDH, SDH, SH. We'll see all of these. If there is any pneumocephalus, Then you come inside, intracranial injuries, which could be contusions or diffuse axonal injury. Coming further inside, is there any intraventricular hemorrhage? And one very important thing is subdural window. So after you are done with this, most people will stop here, है ना कि कोई injury नहीं है. Another very important habit that you should have when interpreting trauma scans is look at subdural window. These are a wider window. You don't have to do anything manually, just change the window to make it a bit wider, right? It's somewhere close to 150 to 200 HU. So look at this case here. In this case, this is our normal brain window, normal soft tissue window that you have for the brain. And what you see here is some sort of maybe subtle, it would be very easy to miss this. But when you just make it a wider window, which we call as a subdural window, look at this. You pick up that there is an extra-axial subdural hematoma, right? So this is something that you have to make it a habit. It will take extra time, but make it a habit. You will not miss these small SDH, all right? So this is what you want to remember here. So this is for subdural window. See, PDFs and all we can sort out. See, the thing is, now we are not preparing for an entrance, right? We are preparing for life, and this is something where you will have so much content, and it's not something that you have to revise and read again and again. It is something that you learn, and anytime you want to go back to, you go back to in-app and just open them. It'll be far more systematic, I believe, rather than having them all over the place. I think it's better this way. So just trust me on this. And it's very difficult to share all of this from every faculty, because these are cases which everybody has, and you would have seen this in your own institutes also, that you can't just share these PDFs. It's not as simple as what we used to have for Unacademy or NEET PG. So you have to trust me on this, and just follow, right? So that's what you have to remember here. That's why the lectures are there as recorded, है ना? So that you can revisit anytime you want. All right. Anyway, so coming back to this, so this is about the approach that you need to remember. So now let's talk about the injuries and their patterns. So when we talk about the scalp injury, so look at this CT here. What are you seeing? You're seeing that there is definite swelling. In addition, there are foci of air, and you are also seeing that there are these metallic foreign bodies, right? So this is some sort of a shrapnel which is there here, and you can also see some sort of a foreign body in the occipital aspect. For subdural window, HU is not decreased. The HU, the window is wider window. So it's somewhere close to 150, 200 HU. So in the CTs, I will show you this in maybe perhaps some reading sessions. I don't know if you have seen. You would see this window here, window and level. So you just make it a bit wider such that, you can just try this out. है ना? अभी अगर report कर रहे हो CT, just try out the different window and levels, just spread it out to become a wider window. And I'll explain all of these terms also as we go along. But, you just experiment such that the image sort of looks blurred, wider window. I don't know how to translate wider window for you, but that is what you try and achieve. Just change it, just play with it. That's what I can tell you. Just play with the windowing a bit, and you would be able to see the image a bit better, and you learn with time what a wider window means. All right, so this is how you pick up a scalp injury. Do not ignore any. Do not ignore. Yeah, so that's what Shubhangi are the windows, right? So most of the W and the L's are automatically there for you. When I press the brain window, when I press the bone window, I get them. But from the brain window, just make it a bit more wider, somewhere close to 150 to 200. Yeah, that's when you will see this image, right? Okay, so that's the window that I'm talking about. So now talking about the scalp injury, so you're going to see this swelling. Apart from that, you have these two hematomas that we frequently see in children, in newborns. So Kifal hematoma versus subgaleal hematoma. It is something we used to study in pediatrics as well. So Kifal hematoma is nothing but EDH, but scalp EDH. So just like how EDH is limited by the dura, by the dura and its attachment to the bone, this is something which is there between the bone and the pericranium in the scalp. So the pericranium is attached at the sutures. Yeah, are you understanding this? The pericranium is attached at the sutures. So what we are gonna have is a localized hematoma. So a Kefal hematoma is like an EDH. Basically, it is limited by the sutures. So this cannot cross the suture lines. And eventually, because it's a localized collection, you may see it becoming dystrophic calcified. And this is one of the spotters also, which I will keep in one of these days. I hope you guys are all seeing the spotters, the rad and nat images, and just checking them off, right? Simultaneously, just complete these. You will be done with so many spotters simultaneously. So, wo bhi dekhte jao. So, this is again one of the spotters that you get, which is a Kefal hematoma, which is calcified. So, you can see a calcified scalp lesion, and that is usually something that is kept as a spotter. Talking about subgaleal hematoma, as the name suggests, this is below the galea aponeurotica in the scalp. So this is something which is not limited. It has no attachment. So this can spread anywhere. So can you see how the scalp is diffusely swollen here, and you see this hyperdensity, and there is nothing stopping it. So this is why it is so dangerous, that it can bleed and it can result in a hypovolemic shock in a child. So this is what is the difference between these two. So that's why Kefal hematomas are not as dangerous as subgaleal hematomas are. So this is about the scalp injuries. Now talking about the fractures here. So this is where I want you all to answer and identify, because this is something that I only have taught you guys when you were studying for NEET PG. So now I want to see if you remember, and then we take it one step ahead from there. What is the first kind of fracture that you are seeing, which is the most common type of fracture that you will usually encounter? Yeah, so this is the linear fracture, right? So this is the most common type that you want to describe. So this is a linear fracture here. Can somebody tell me, why is this not a suture? Why is this a suture and why is this a fracture? What is the difference between a linear fracture or a suture line which is not fused? Or fused. Yes, so the margins are serration. So the sutures are going to be serrated in margins. If you look closely, these are going to be uneven. And the second pointer is these will have cortications, right? So you're going to see a cortical rim around the sutures here. So one is definitely the serrations, and second is a very well white cortical margin that you will see in the sutures, which you will not in a fracture. It's going to be a sharp line without any cortication. So, and again, the third point is sutures are going to be bilaterally symmetrical. So these are all questions that you get asked in case presentations and all, right? So this is what you want to remember as far as fracture versus suture is concerned. Second fracture, what do you think is this here? What is this fracture here? So this is the, see guys, can you tell me one difference between this image and image number 3? So we are talking about bone windows and bone recons, right? So this is what a bone window is. If you see this image, doesn't it look higher resolution? Doesn't it look sharper to you, that I can make out the cortex and the medullary junction much more better than this one? So are you understanding that this is the bone window, that button you press, that is bone window. This one, correct, is the recon. So in the bone recons, which are specially reconstructed harder, sharper reconstructions, these are going to be your better visualizing corticomedullary junction images, right? So this is what is the difference that I was talking about. So this is a depressed fracture, correct? What is the importance of a depressed fracture? These are very significant clinically. This is something, yes, which we learn as signature fracture, because they tell us about the thing which has been used for trauma, but now we don't care about that. What we care about is what lies beneath it. So depressed fractures are going to be associated with more risk of contusions, right? So there's going to be higher risk of contusions in depressed fracture, because the bony fragment can leak here. Then they are also associated with higher chances of CSF leaks, right? So they can injure the meninges, and there could be CSF leaks which are associated, which could leak into the dura, resulting in subdural collections. Yeah. And the third importance is they can, injure the dural venous sinuses, they can injure the jugular bulb, so they can result in vascular injury, like more commonly venous injuries. So this is the importance why depressed fractures are very important. You have to make sure that you see the brain, underlying brain, very carefully once you encounter these. What about this one? You can see here on the side, there is a baby, there's a 3-year-old child here. What kind of a morphology do you see? It seems like the brain here is flattened. Yeah, so there is no breach, there is no cortical breach, there is no fracture line. But what I see here is that the brain is deformed, isn't it? So इसको क्या बोलते हैं? इसको बोलते हैं pond fracture, or we can also call it a ping pong fracture. And this is also one of the things you get as a spotter. है ना, स्पॉटर में आता है, क्विजेज में आता है. सो पिंग पोंग फ्रैक्चर, पॉन्ड फ्रैक्चर, वेयर because the baby's bones are very flexible and malleable, they don't break but they get deformed, right? So this is what you see usually in infants or children, young children, is what you see here. This is what I was talking about. Yeah, so this is the sphenoid, this is the clivus of the occiput, and what do you see? I see that there is a separation of the bone. You remember I had shown you this image on the axial section. So this is what is your spheno, depressed versus pond. Shubhangi, depressed is a break, right? So here there is no bony break, there is no fracture, there is just deformation. So what you are seeing here is that there is no break and then bone getting depressed. This one without any break, it's like a ping pong ball. Ball ko aapne aise compress kara, it just got compressed, it did not break. That's the difference, right? Okay, so going on to the next one, this is the sutural diastasis. So sutural diastasis you can see in kids where the sutures have not been fused. But what is the most common sutural diastasis that you see is this one. It is the one which fuses the latest, as I said, somewhere close to 17, 18 years of age, which is the spheno-occipital synchondrosis, right? So what you will report this as, there is diastasis of the spheno-occipital synchondrosis. Okay, so this is sutural diastatic fracture, diastasis, separation of the sutures. Ye kya hai? What is this one? Very easy. This is comminuted fracture. Comminuted fracture means anytime the fracture has more than or equal to 3 fragments, right? So anything more than 3 is a comminuted fracture. And what is this one? Can somebody tell me what this is? Very, very important question for exam, can come as a spotter also. If I tell you there is a child, no, this is not brain herniation. If I tell you there's a child, see the age is a 2-year-old baby. Good. This is a growing skull fracture. Any other name that you know for growing skull fracture? Also known as? Good. Also known as leptomeningeal cyst. Yeah, so this is a the name itself tells you everything. So few pointers that you want to know. This is something which is a complication of a fracture that is seen in younger kids who are less than 3 years. It is a delayed complication. It is not something you will see at presentation. The mother or the parents will come to you, you know, somewhere close to 2 months after the trauma, that the fracture is growing. I am having a mass which is coming. जो fracture हुआ था वो बढ़ रहा है. That's why the name is growing skull fracture. And what it is a leptomeningeal cyst. It's a CSF collection. You see that the density is CSF, hence the name cyst. And why leptomeningeal? Yes, because in children, in these younger kids, what happens is that the dura and the arachnoid are very closely adherent to the sutures, right? They're very, very closely adherent to the sutures and the bones per se. So whenever there is a fracture, there is associated meningeal tear also. There's rupture of the arachnoid from which the CSF is going to come out and it's going to form this cystic lesion, which gives the appearance of a growing skull fracture. And what it will lead to, basically this constant flow of CSF results in a non-healing fracture. Yeah, so whenever you have an associated meningeal tear, that is the pathophysiology, associated meningeal tear, you are going to have this leptomeningeal cyst. Okay, understood this? So this is about the types of skull fractures. Talking about temporal bone fractures, just to finish this off right here, we will be having temporal bone anatomy pathology sessions. But now talking about temporal bone fracture. So when you see that the bone is the fracture is this is the petrous bone, right? So this is the repeat growing skull fracture. So in one line, if I can tell you, it is a delayed complication of a fracture in children who are younger. There is associated dura and arachnoid which tears with the fracture, which results in the herniation of CSF outside, forming a cyst which does not allow the fracture to heal. Okay, so this is about growing skull. Coming back to temporal bone fracture, so when you see there's a petrous bone apex, and if you see the fracture line going along it, you remember the word along, and that is a longitudinal fracture. Yeah, I don't know if you remember this. So this is along and this is longitudinal fracture, right? So what you're going to see here, it is parallel, and you can also see that this reaches the middle ear. The one filled with air is the tympanic part of the temporal bone, and it reaches there. So this is the one associated more with middle ear trauma, so conductive hearing loss, ossicular injury, tympanic membrane rupture. On the other hand, if it is perpendicular to the petrous apex or the temporal bone, it is the one we call as transverse, and it's associated more with inner ear. You can see this medial part. This is the inner ear here. So the otic capsule gets injured here, resulting more in SNHL, seventh nerve injury, and labyrinth and cochlear nerve. So this is what you need to remember here. Yeah. Now talking about the hematomas and the injury. So we've done scalp, we've done bone, we've done, now we are on to extra-axial injuries. Extra-axial injury outside the dura is extradural hematoma. Till now, I think we were at this point, most common cause of EDH, and you would all answer middle meningeal artery. But now we are in the radiology part of things, where now we learn more that, oh, that middle meningeal artery is only 90%. Now, what is very important to know also is that 10% of these EDHs are also venous, right? So this is what now you add on to your knowledge. So arterial, definitely what you know is correct. Most common cause is the middle meningeal artery, the anterior division which runs near the pterion, and that's why pterional injuries, the squamous part of temporal bone fractures usually result in vascular injury resulting in EDH. 10% of these EDHs are venous, and these are lower pressure. So they have a better prognosis than arterial injury, and they result because of dural venous sinus getting injured, right? So dural venous sinus injuries can also result in EDH. Very, very interesting to know that 90 to 95% are near the skull fractures, So whenever you see an EDH, always see the bone recon to rule out a fracture. Whenever you see a fracture, always change your window a bit if you're not picking an EDH to see if there is any extra-axial hematoma or not. So works both ways, right? That's what you have to remember here. Do EDHs cross suture lines? Yes or no? Do they cross suture lines? For NEET PG, our answer would have been no, ma'am. They do not cross the suture lines. But again, now we are on the other side. 10% do cross suture lines. What are these 10%? What are the 10% which may cross the suture lines? These 10% are the ones where, what if you have associated sutural fracture? What if you have an associated sutural diastasis only? In that case, obviously, it can cross the sutures. So the point here is that the dura, right? The dura is attached at the sutures. So wherever you have dural attachment, the EDH will not be able to cross it. But what if there is a fracture running here only? Then nothing is stopping, right? Then it can cross over. So those are the 10% where it may cross the suture line. And this is something that you see in children again, right? Where the sutures have not been fused. So most of the times, if there are crossing the suture, there will be in a child. Okay. So that is what we need to know. Do they cross the midline? Yes, they may very well cross the midline. Nothing is stopping them in the midline. Very important. What are the important EDHs? What are the ones where the surgeon will decompress? So first, diameter. What is the significant diameter? Anybody can tell me for an EDH? So you measure the largest diameter and report. Not 5 mm, 15 mm. So anything more than 1.5 centimeter is an indication of decompression. What volume? We must always report the volume of all hematomas, and we will have Ravi teaching you how to measure the volume, not me. Yes, more than 30 cc. So 30 cc volume is what is very important. What midline shift is always significant, trauma, non-trauma, any case of raised ICP, any midline shift of more than 5 millimeters. How do you measure the midline shift? So you see the fox here. So you draw a line from the middle, and then you see the septum pellucidum, right? So you see the septum pellucidum, the distance between the two is going to be your midline shift. So a line through the middle. How do you know the middle? So you see the fox. So draw a line through the fox and then draw a line through the septum pellucidum. See the difference. That is how we calculate the midline shift. Any midline shift more than 5 millimeters. What is the swirl sign? The swirl sign is this. When you see that there are areas of hypodensity within the hyperdense hematoma, it indicates that there is active bleed which is happening, which is always a poor prognostic sign. So these are the indications of decompression that you want to remember, or the important measurements that you want to be aware of. Very important for life. This is something we don't learn. इतना आपको already शायद आता होगा. This is something that you want to remember. Yes, GCS and all clinically, definitely we will talk about that. But as a radiologist, what you will see, this is what we will be reporting. GCS, the neurosurgeon knows, no, that you don't have to tell them. So this is what we want to remember. Swirl sign is Saurabh, when you see areas of hypo, can you see this hematoma here? It is not crossing the sutures, right? So that's how I know it's an EDH. Secondly, can you see कि ये white है and then there are these black hypodense areas within the hyperdensity? So that's what is the swirl sign. It indicates active bleeding within the hematoma, means a poorer prognosis. Venous EDH, बहुत important for us to know. So when any fracture will cross the dural venous sinus, that is going to result in a venous EDH, which is usually low pressure. You should know the sites. What are the usual sites? So this is one of the most common sites. This is what we report as a vertex EDH. Anytime you see something like this on the vertex, you know it is a venous EDH. We are not worried too much about these EDHs. You can see how the superior sagittal sinus is displaced downwards. So this is your vertex venous EDH. This is again something that you see very frequently in life also, in exams also, in spotters also. This is your anterior temporal venous EDH. Anterior temporal venous EDH results from what? It results from injury to sphenoparietal sinus. So vertex is from superior sagittal sinus injury. This is sphenoparietal sinus injury. You can have transverse sinus posterior fossa injury. And what is this? Can somebody pick up the finding here? Even though there is an arrow placed for your convenience, if there was no arrow, I think a lot of you would have missed this. What is this that you are seeing here? Can somebody tell me this? Yeah, very nice, Ramya. So this is a clival EDH, right? So clival EDH is again something that you may miss. So you want to be on a lookout for till the clivus, till the brainstem, So this is the clival EDH, which is again a venous EDH. So these are three common sites of venous EDHs that are frequently missed. This is very frequently missed. This is very frequently missed. So always keep an eye out for these, okay? Right. Talking about SDH. So SDH subdura, between the dura and the arachnoid, you have the bridging veins. So these bridging veins get injured, resulting in SDH. These are most commonly along the cerebral convexities. So how do we know whether it's EDH or SDH, like we were being asked? So one most important thing is this freely crosses the sutures, but can it cross the midline? No, this cannot cross the midline. So this is not limited by sutures, but it cannot cross the midline here because our attachment of the dura lies here. And again, these are the three most common patterns you will see. Just remember this image and you will never get confused whether it's an EDH or SDH. SDH will always be one of these three. So either it will be this crescentric shaped hematoma that you see, which is crossing the suture lines, which is your most common convexity wala SDH. Second is this along the fox cerebri, which is your falcine SDH. And this one posteriorly that you see is your tentorial SDH. Remember this. When you see it either along the midline, so either it is your falcine SDH, it is your tentorial SDH, or it is your convexity SDH. Convexity obviously is your most common one. Tentorial is the one that you miss a lot of times. Okay, so this is what you want to know. These can be very thin, which may just present as the tentorium appearing a bit thickened. Anyways, it is hyperdense, है ना? So it will just appear as a thickened tentorium. So tentorial SDHs are missed quite frequently. And one tip which I can tell you, which you will never miss a tentorial SDHs, just see a coronal. If rarely do we make a coronal image. जब हम brain CTs report कर रहे हैं, tell me, have you ever actually seen a coronal or a sagittal image ever? No, we just see the axial फटाफट and we go to the next case. If you will just make a coronal and you scroll through it, you will never miss tentorial SDH. Okay, it is missed on axial, but coronal mein it is very clearly seen as the thickening. So that is one tip that I can give you, is see the coronal image. Can it be biconvex? No. These are usually concavo-convex, but personal advice, अब उसको छोड़ दो पीछे, है ना? Idli shape, lens shape, crescent shape, this is all gone now. Now the shape is not going to help you a lot. Yeah, this image is axial. Okay, how many days has it been in radiology? So yeah, this is axial, right? So this will be better seen in coronal. Okay, Fox calcification versus false sign SDH is the density, right? So it's gonna be far more dense than this. So density will help. All right, what was I saying? Yeah, so the shapes won't help us more. It will basically be the location, whether it's crossing the sutures or not. Okay, so that's what we want to do. All right. Yeah. Now talking about so basically it's the suture crossing and presence in the midline. Absolutely. Yes. And still, abhi lag raha hoga na, ma'am is so confident. But when you see a lot of cases, you can't say. You can't say till the very end until neurosurgeon opens and tells you that it was EDH or SDH. So, it all sounds good in theory, but a lot of times you may actually end up not knowing only. It is sometimes, it is located in such a way, the shape is conflicting with the sutures, and so sometimes you just have to say that it is extra-axial hematoma and leave it at that. So you say that it is very non-specific and there are no specific signs to comment whether it is SDH or EDH, and then you just call it extra-axial hematoma. So there will be cases like that as well. All right, what about SDH? Now SDH is not as dangerous as EDH and doesn't always need decompression. So one is the diameter. Who will tell me what diameter do you want to tell? Let's see, अभी हम बात करेंगे with a neurosurgeon की ऐसे केस में क्या करना है. What do you want us to do? Do you want us to just falsely tell you कि ज़्यादा EDH लग रहा है, SDH लग रहा है? What do you want us to do? So we'll talk about that as well. But anyways, what diameter do you think SDHs are significant beyond? That was 1.5 centimeter. This is 2 centimeter. So one is more than 2 centimeter, and something very interesting is that if they cause a midline shift, which is not more than 5 mm, ऐसा नहीं है. They say that if the midline shift is more than 3 millimeters of the thickness of the SDH, मतलब क्या हुआ? That if my SDH diameter, let's say this SDH diameter is 8 millimeters, and the midline shift that I am having here is 6 millimeters, then it is not significant. Yeah. So if the midline shift is 3 millimeters more, right, 3 millimeters more than the diameter of this, then it is significant. It's just theory, but something that you may want to know. So in such cases, you just report what the midline shift is, what the diameter of SDH is. That is what is the takeaway here, that always measure the diameter, always measure the midline shift, right? Okay. What about chronic? What about the density? So again, very, very important concept for all of you young radiologists here is that how the HU changes. We know acute hematomas are hyperdense. As the time passes, what we are going to see is the dictum here that you want to remember is that 1.5 Hounsfield unit per day decrease happens. So जैसे जैसे आप इसको सब acute से chronic करते जाओगे, what will happen? The density keeps going down. So usually by the time it's somewhere close to 14 days, it becomes isodense to CSF. All right. So this is what you want to remember, and then it may become hypodense also. All right. So more than 14 days, it becomes hypodense. So this is about the CT density. Acute hematomas, hyperdense. Subacute hematomas, isodense. Chronic hematomas, hypodense. So this is what you want to remember. 1.5 HU कम होता जाएगा. So this is how you will miss. Can you see how in this case, at the first glance, नॉर्मल सीटी लग रहा है. अब ध्यान से अगर देखो, कांट यू सी दैट देर आर बायलेटरल सबड्यूरल आइसोडेंस कलेक्शंस. So in such cases, MRI comes in very handy. Window change comes in very handy. And what also you will see, there are certain signs which have been described. So what happens is, as the hematomas become more and more chronic, they form these membranes, है ना, इसके अंदर membranes बनती है. And with more membrane formation, there is higher risk of rebleeding within these hematomas. So can you see how there are these loculations within the hematoma? Can you see this net-like effect? इसको हमने नाम दिया है Parfait effect. You know what is a parfait? um it's a dessert with like a set custard and jelly, and I don't want to go into parfait ke details, but it sets, so the hematoma kind of sets and it becomes this jelly custard like consistency, and you will have these pockets. Okay, so this is what we see here. There is a chronic SDH with these collections here within it, which indicate secondary membrane formation. That's how you report this as, okay, that there is a loculated subdural collection with a predominant hypodense signal, hypodense density with areas of hyperdensity. Okay, so this is what you want to remember. MRI comes in very handy here because, as we discussed, I bleed, I die, bleed, die, bleed, bleed, die, die will help you age these very well. So you can see how there are these different ages of collection here. You see this hypointensity, you may see this hypointensity with these heterogeneous area. And can you see how there is this hematocrit effect? इसको बोलते हैं hematocrit effect, where in the posterior aspect you start to see this getting settled, right? You see this hyper intensity in the posterior aspect. Okay, so इसको हम नाम देते हैं hematocrit effect. Not very very important, it's just that the blood, the cells settle down, creating this hyper intensity. In addition, you see these membranes very well. इसमें imagine करना पड़ रहा था parfait को. इसमें you can see the membranes on the MRI in chronic collections, subacute to chronic collections. SH का most common cause, is it trauma or is it non-traumatic? Aneurysmal SH? It is definitely trauma. Far more people have trauma than aneurysms. So traumatic SH is the most common cause. Any difference in the appearance? Can you always say, looking at the SH, whether it's traumatic or it's non-traumatic? You can't, So if I see a case of SH in my trauma center, how do I decide whether I should do a CT angio to rule out aneurysm or not? A lot of times you may not be able to distinguish, but if it is a focal patchy SH, right, somewhere close to the sulci, if I'm just seeing that there's a fracture and there are just few sulcal hyperdensities here, then it is likely to be a traumatic SH. But if it is central, it is somewhere close to the perimesencephalic cisterns. ये भी anatomy थोड़ा थोड़ा, I hope you know. This is the midbrain. So this is the interpeduncular cistern. These are your sylvian cisterns. These are interhemispheric cistern. इसकी भी बात करेंगे हम जल्द ही. But if you see this central, then you want to rule out aneurysmal SH. In such cases, you definitely want to do a CT angiography. Okay. Star of death is definitely non-traumatic, right? So this is where you see a basilar cistern getting involved. You definitely want to do a CT angiography. Who will tell me this diagnosis? ये एकदम एक spotter है. If I ask you what is this, is it SH, SDH or EDH? Is it aneurysmal, non-aneurysmal? Is it arterial? Is it venous? You want to tell me everything. I want 3 answers here. Where is it located? First of all, this is the midbrain. So this is in the interpeduncular cistern. How I will report this is कि interpeduncular cistern में hyperdensity है. What will be my impression? Is it aneurysmal SH? Okay, So it is central. That's why you're saying aneurysmal SH. Fair enough. So I agree with half here that this is an this is definitely an SH. What this is a perimesencephalic SH. This is a very specific type where you don't see SH anywhere. I just see it around the midbrain. So इसका नाम है perimesencephalic SAH, and this is something that is venous in origin, and this is something which is non aneurysmal. So इसका पूरा नाम जानना, it's a very scary name. इसका पूरा नाम है non aneurysmal perimesencephalic SH. So sounds very scary, looks like some prime minister scheme, but it is not. All right, what it is a non-aneurysmal perimesencephalic subarachnoid hemorrhage. All right, so it is basically something where you tell the patient and the neurosurgeon that name is scary, condition is very benign. It's a venous bleed, will solve on its own, nothing needs to be done. So this is something which is a very specific entity जहाँ पे और कहीं कुछ नहीं है, no other SH, just this localized interpeduncular cistern hyperdensity. It's a perimesencephalic non-aneurysmal SH. Okay, learned something new today. Can I go on to the next one? So what is the most sensitive sequence for SH, or most sensitive modality for SH? That is MRI, and it is the flare sequence. So flare is the most sensitive for picking up SH. So look at this, itna chota sa SH in the sulcal spaces will definitely miss it on the CT, and flare picks it up very nicely. Again, a very important concept I want to teach you. SDH versus subdural hygromine CT, can't distinguish there. If SDH is, isodense, if it becomes isodense, we can't distinguish. So prior imaging will help, if you see the evolution, that's the only way you can distinguish. But if you see just one time point, isodense, we can't distinguish. Lamina terminalis की भी बात करेंगे. All cisterns and all anatomy I'll teach you. Don't worry. Next week I'll teach you, okay? Right. Let's come to this. When can you get, so this is a very important question that you get asked, if you become thoda senior JRs, your seniors will ask you this question, that what are the DDs of hyperintensity in the sulcal spaces? Can somebody tell me this? I want answers from you here. What are the DDs of this? Don't tell me SH. That is one I am only telling, that SH will be one cause of sulcal hyperintensity. What are the other DDs of this? Very good. Very nice. One is meningitis. Meningitis can have this flare hyperintensity. What you've actually said as ruptured dermoid, I wanted to show you this as a spotter. Can you look at these two cases and tell me the diagnosis? Again, comes as a spotter in lots of quizzes. ऐसा दिख रहा है यहाँ पे कि हाइपर इंटेंसिटी है इन द सर्कल स्पेसेस, एंड देन वी गो डाउन हियर एंड यू सी दैट देयर इज a dermoid sitting. So a ruptured dermoid, as you know, will have fatty components. So this fat leaks out here in the sulcal spaces, and that can result in this hyperintensity, right? So that is a ruptured dermoid that also you want to consider. Then very nice. A lot of you are saying hyperbaric oxygen. So that's again a artifactual thing where hyperbaric oxygen, if the patient has been given, it can result in this pseudo hyperintensity. Another cause is polycythemia on similar lines, right? So polycythemia, sluggish blood flow, it will result in this hyperintensity. If you have, if there is contrast, intrathecal contrast, either you have injected or you have given intravenous gadolinium where the patient has had a rupture of, blood-brain barrier. If the disruption of blood-brain barrier is there for any reason, that can result in this. Moya, very rarely, if you have collaterals, they may present like this if there are too many collaterals. So yeah, moya as well. Cortical necrosis doesn't result in hyperintensity on a flare sequence. Okay, so you may in maybe subacute stages of thrombosis, it may appear hyperintense on flare in one isolated space, but yeah, usually not a part of this list. Apart from that, you can just have a flow artifact. So it could be a CSF flow artifact as well. So these are all the causes of flare hyperintensity that you have. Yeah. So yeah, the IV sign which is there in the slower uh, in the collateral vessels can result in sulcal hyperintensity as well. All right. So these are all the things that you want to know as far as the DDs of this is concerned. Blood-brain barrier disruption means, let's say there is a tumor which has resulted in disruption of the blood-brain barrier, then the gadolinium can cross over and that can result in hyperintensity. Okay. So this is what you need to know. Another interpretation of pseudo SH is on CT itself. So this was here we are talking about flare, है ना? अब हम CT में ही बात करते हैं that the brain itself is so hypodense that the sulcal spaces, the cisterns start to appear hyperdense. So this is one more way of calling it pseudo SH, and diagnosis is pretty simple, which is cerebral edema. Just like we have white cerebellum sign, similarly brain ही उतना hypodense हो गया that it's a pseudo hyperdensity that you see. Understood? So these are two kinds of pseudo SH things that you want to remember. Fine. Now talking about simple stuff. So contusions can be there. So contusions is the most common intra-axial injury. You may have hemorrhagic contusions or you may have non-hemorrhagic contusions. So hyperdense contusions or just hypodense contusions. White cerebellum sign also I will teach you as we go along, है ना, brain death में पढ़ाऊंगी. So contusion, उसमें क्या है, nothing much. Basically the cerebellum appears whiter, hyperdense compared to the rest of the brain. It's not because the cerebellum is a problem, it's the rest of the brain which is hyperdense. That's all. Okay, right. So this is the most common intra-axial injury and it is usually superficial. One dictum you want to remember, guys. Why is flare the better sequence and not GRE? Good, very good question. So see, GRE and gradient echo will pick up hematomas when there is a collection, right? When there's a loculated collection here, GRE will also show you this. Okay. But here, Shubhangi, the thing is, what will flare show? The flare will show hyperintensity. Even GRE will show you loss of signal. It will also show you susceptibility here. But this list is basically what all will mimic this, what all will mimic this on flare. Yeah, and flare is very sensitive for picking up this blood in the sulcal spaces. This is where if you do a gradient, you might just miss because look at the rest of the sulcal spaces. They're also looking black, right? So you are not going to be picking up SH better on gradient, but for other things, other hematomas, gradient is going to be better. But for SH, flare is much better than gradient because it will also be loss of signal, which you anyways are seeing on flare, right? That's why. That is what you want to remember here. Coming to contusions now. So these are more superficial. One dictum that you want to remember in the brain trauma is the deeper you go, the poorer the prognosis becomes, right? So these contusions are usually superficial. Their only problem is the mass effect and the edema. So as we discussed, they are usually gonna warrant a repeat CT because they enlarge. They tend to enlarge in 12 to 24 hours. What are the most common locations? So the most common locations are what you see here. So they are the frontal lobes, the anterior temporal lobes. Anybody can tell me why? Why these are the most common areas? This is again a question that you get asked a lot. That what is the most common site of contusion and why? Yeah, because there are a lot of bony projections here, right? So here you have the sphenoid, you have the petrous apex coming in, you have the cribriform plate here. So here you have all of your projections, bony skull projections are here. So anytime you have a trauma, anytime there is a closed compartment injury, the brain shears against these bony projections and you have these hemorrhagic contusions more commonly in the frontal, basifrontal, anterior temporal lobes. Coop counter coop, again, I hope you know coop counter coop. What is there? So basically you have a direct impact at one side. So let's say this is the brain. I have direct impact here. Diagonally opposite to it also, we will have the shearing of the brain. So you will see diagonally opposite areas पे injury. So you can see a scalp injury here. Look at this subtle tentorial SDH here, and then you see a hemorrhagic contusion diagonally opposite on the right side. So anytime you see a hemorrhagic contusion, here, always make it a point that you check out that diagonally opposite there is no trauma. So this is what you have to remember as far as coup counter coup is concerned. Talking about diffuse axonal injury, so as the name says, it is axonal shearing, the tearing of the axons, and it happens because of deceleration. The white matter and the gray matter are of different densities. So anytime there is sudden deceleration in high energy trauma, the axons end up getting torn, which results in these small micro bleeds. And now it's not the cortex like contusions, it is either the gray white matter junction or further deeper into the corpus callosum and the brainstem. So this is where we have the CT, which may be normal, or you can see these small micro bleeds. MRI, three sequences will show you these, so you can pick them up on diffusion, you can pick them up on flare, and gradient remains the most sensitive. SWI is much better than your T2 star gradient images. So we do learn this in NEET PG level as well, that susceptibility weighted imaging is the most important for DI. And now there are lots of studies that we have on diffusion tensor images as well, right? So white matter injury result and the impact, the result that you see in DTI. So DTI is not something we do in routine practice, right? But lots of research going on. We had a thesis in AIMS also about DTI in trauma, something which is being researched a lot now. So this is something that we don't really do it in routine practice till now, but we will start doing them very soon. So DTI also has a very big role in white matter tract injuries. That's what you want to know. What is DTI? If you don't know, we will discuss. Talking about the Adams staging of diffuse axonal injury. So stage 1 is the gray matter white matter junction. So most common sites are frontal lobe, temporal lobe, internal capsule, cerebellum. Stage 2 is when the corpus callosum gets involved, and stage 3 is brainstem, right? So this is the Adams staging. So if I can show you a few cases here. So look at this. This is how they are not at the cortex. They are at the gray white matter junction, small bleeds. This is when you suspect a diffuse axonal injury. Look here, you can see this at the corpus callosum, right? Can you see these micro bleeds at corpus callosum? And then stage 3, you will see them involving the brainstem. All right. So these are the 3 Adams stages of diffuse axonal injury. MRI is obviously better. So you see there's a T2 star GRE image where you see the susceptibility of the microbleeds better picked up. This is a susceptibility weighted imaging where you can see these bleeds even better, right? So this is what you want to remember for DAI. DVI is the same, right? So diffuse vascular injury is the extreme spectrum of DI, which will look exactly same. Radiologically, can I distinguish whether it is DI or DVI? You can't, So theory wise, this is just the extreme severe spectrum of diffuse axonal injury where there are chota vascular bleeds also. Okay. So that is the term that you just want to be aware of. Intraventricular hemorrhage, you can see here in the DI MRI findings is nothing. It's just these black spots that you see, which we call as blooming, right? So we are going to see the susceptibility basically. On MRI, we are going to see susceptibility. On your flare images, diffusion weighted images, you're going to see T2 hyperintensity, flare hyperintensity. On the gradient images, you're going to see susceptibility, meaning loss of signal. So black dots, right? Does anybody want to tell me DDs for this? What are the DDs for multifocal areas of blooming? Again, a very pet question that you get asked. These are the lists, that we keep building up in all our classes. What are the DDs for these black dots? One is diffuse axonal injury. Yes, there can be calcified granulomas. So TB, NCC, calcified granulomas will cause susceptibility. Hypertensive bleed, more than hypertensive, what you have to remember here is cerebral amyloid angiopathy. That's a very important differential which can lead to lots of these small vessels, right? Cerebral amyloid angiopathy. What else? Septic emboli, right? So septic emboli to the brain can result in all of these vasculitis. So you can have vasculitis, which can result in multifocal small bleeds. What else? AVM, not really, will not have these micro bleeds. Air emboli, very rarely. So diffuse axonal injury, air emboli. So this is what we want to remember. Shouldn't calcified granuloma appear more wide? No, no. We're talking about MRI, right? We're not talking about CT. We're talking about MRI. So calcium and hemorrhage. Both of these are gonna induce susceptibility. All right. That's what you want to remember. Right. Any, yes, very nice. Any micro angiopathy for that matter, you know. So if you have DIC, you have TTP. So any cause of small vessel vasculitis basically will result in these small bleeds. Okay, so this is something, again, a list that you want to remember. DDs for multifocal blooming. Okay, moving on to IVH. So IVH is going to be because of a venous injury. Subependymal veins ka tearing will result in this, and they may cause obstructive hydrocephalus by the clots blocking the CSF flow. Pneumocephalus is the presence of air. So here, this is usually low pressure, not a problem. You know, you can just basically, these are not something which are indications of decompression. See, scout image somebody was asking. Now you know, scout, what is scout? This is the tomo image, no, that we take before acquisition. So this is how the CT cuts are planned. So this is your scout image, and it's also a good idea. It shows you the air very well, you know. So you see the air here, pneumocephalus here. On the CT, you see these black spots here, low Hounsfield. You can always measure the Hounsfield if you are confused. And one of the DDs here, you know, is the presence of fat. A lot of times there is the presence of this fat in the subarachnoid space. Yeah, scout looks like X-ray. It's the X-ray only. It's the preliminary X-ray that we take. Haven't you seen a CT acquisition? है ना? तो it's like an X-ray, but it's not an X-ray. It's a very low energy, low radiation X-ray that we take, right? Very high KVP topogram. Yes. So that is what you want to remember. What are you seeing here is the presence of fat. So this is one of the DDs for pneumocephalus, where you can sometimes mistakenly report this fat as air. So just measure the density. Okay. Right. And finally, what you are seeing here, you can see how there is tethering. So when you see this tethering, this pointy end of the frontal lobe, that is when you know that there is some sort of pressure, and इसको हम नाम देते हैं tension pneumocephalus. So this has been likened to a mountain. So this is the Mount Fuji sign. So this is your tension pneumocephalus. When you start to see this tethering of the frontal lobes, that's when you know that there is pressure. Otherwise, pneumocephalus, not very, very important. Coming to the secondary effects, primary injuries ho gayi, everybody on the same page. What are the herniations? What are the secondary impact of the trauma? Enlarged frontal sinus, you will see the bones, right? So, I mean, good thought, but you just scroll and you will know whether it is intra sinus or outside the sinus. Yeah, so that's not a problem. And obviously, frontal sinus will not have this mass effect on the brain, will not have the tethering of the brain parenchyma, right? So now talking about the herniation, so the different classifications, you can get a theory question on this. You can be asked, questions in Viva. So most common kind of herniation that we have is subfalcine herniation, where you have the herniation of which lobe? It's the cingulate gyrus, right? So the cingulate gyrus herniates below the fox, hence the subfalcine herniation. So यहाँ पे क्या हो जाएगा? Cingulate gyrus is herniating. What you have to remember here, that what are the associated complications? One, because of the cingulate gyrus herniation, the foramen of Monro can get obstructed. So foramen of Monro obstruction can result in hydrocephalus. Very nice. ACA, the pericallosal branch of anterior cerebral artery just runs below this. So this can result in secondary vascular injury to ACA. Or you can also have internal cerebral veins, which are also coursing here, which can get injured, right? So this is what you want to remember. So this is the most common herniation. Then you may also have descending transtentorial herniation. Ascending bhi hota hai, but that's very rare. Through the tentorium, what is more common is descending transtentorial herniation. it could be central, but what is more common is lateral. So central is where you have the uncus going down. In lateral DTH, we have uncus as well as the parahippocampal gyrus, which is going down. Okay, so central DTH, we have the brainstem only, which is going herniating through the center. In lateral DTH, we may have uncus or the parahippocampal gyrus, which is going down. So DTH meaning it's the second most common herniation, descending transtentorial herniation. You may also have tonsillar herniation. Most of these patients will not present to you for a CT. They will usually uh, be declared by then. They'll usually be M1. So tonsillar herniation and extracranial herniation, anytime some sort of a decompressive craniectomy has been done, you can have brain herniating outside. Okay, Carnohan's notch ki baat karenge abhi. I will talk about all of these in detail. So can you tell me what is the herniation here? You can see that there is an SDH here. You have acute on chronic SDH with a significant midline shift. As I said, how do we calculate the midline shift? Draw a line through the fox and you see the septum. So this is what you measure here. This is the midline shift and you see that there is herniation of the cingulate gyrus. So this is your subfalcine herniation, right? So this is your subfalcine herniation. You can see it on the coronal view and you can see how it can compress the foramen of Monro. It will efface the ipsilateral lateral ventricle and the other one contralateral will be dilated. Okay, so this is subfalcine herniation. Oh. Then what you have here is the transtentorial herniation. So this is what is very, very important. So what you see here, can you see how this sided temporal horn is enlarged and this side it's completely effaced? This is the midbrain which is deformed and what you see is that the uncus has come down. So let's understand the concept of what happens, right? So lateral, this is what I was trying to say. In lateral DTH, what you have is the uncus and the parahippocampal gyrus which comes down. So what will happen? In this part, I have the third cranial nerve, yeah, oculomotor nerve, and we have the PCA which is running here in the ambient cistern. Okay, so this is the PCA. So what will happen when the uncus comes down at this level? It can result in the third cranial nerve compression. So ipsilateral third cranial nerve compression can be there, which the neurosurgeon will say as a down and out pupil, a dilated pupil, right? So down and out with a dilated pupil. So this is a sign of third cranial nerve. We call this as Hutchison's pupil. Don't need to know as a radiologist, but ipsilateral third cranial nerve palsy can be there. What else can you have? You can have PCA compression. So you can also have a PCA infarct which can develop. And then what happens? So now this uncus is herniated and beyond here you have a sharp tentorium. So this sided crus will compress against the tentorium here. So what will you see? You will have compression of this sided crus. So let's say I have a hematoma on the right side. राइट साइडेड ईडीएच है, राइट साइडेड herniation है, but now what is happening? Left sided crus is pressing against this tentorium. So what kind of compression this patient will have? In the crus we have corticospinal tracts, yeah, which have not crossed yet. So what we are gonna have now is ipsilateral weakness, है ना? So ipsilateral hemiplegia हो जाएगा. So this is what is called as the false localizing sign. Did you understand this? That contralateral crus got compressed and that is why I have ipsilateral, original to what sided hematoma I have. I have ipsilateral hemiplegia. So this is what we call as the false localizing sign, which is called as the Carnohan's notch. So this is the Carnohan's notch or the Carnohan's phenomenon, which is ipsilateral hemiplegia. So this is what is the clinical aspect. In addition, you may also have durate hemorrhages. What are durate hemorrhages? These are hemorrhages in the brain stem that you will see in cases of descending transtentorial herniations, right? And finally, something that you may or may not encounter is the tonsillar herniation. CVJ की भी class करेंगे. CVJ is probably one of the toughest topics. So here this is a McRae's line. McRae line क्या होता है, किसी को पता है? So you draw a line from basion and opistheon इन सब की बात करेंगे. And if the tonsil is below 5 mm of this line, this is what we call as a tonsillar herniation inferiorly. On an axial section, you will see the tonsils and you will see the space getting effaced. You see the medulla and you see the tonsils which are effacing the CSF spaces, right? So this is what is a tonsillar herniation that you see here, right? And finally, two herniations which you want to know. Yeah, Chiari is defined on the basis of this line. Absolutely. What you are seeing here is an extracranial herniation, right? So this is our extracranial herniation in a case of a decompressive craniectomy that has been done and you have raised ICP, it can come out. And this is what comes as a spotter. It is paradoxical, right? That instead of going out, herniation here, it's the brain is sinking. So what is this called? It's called as a paradoxical herniation, also called as a sinking flap syndrome. So what happens is anytime the atmospheric pressure exceeds the intracranial pressure, ICP इतना कम हो गया कि atmospheric pressure is exceeding the ICP, you will have this paradoxical inward movement of the brain. Yeah, so this is what is called as the sinking flap syndrome is what you want to remember here. On the axial section, the tonsillar herniation, what you will see is normally I will have the medulla in the center and I will have CSF all around it. यहाँ पे क्या हो गया? Because the tonsil is coming here at this level, there is crowding. Yeah, you see here, medulla hai, or the cervicomedullary junction is there and you have the tonsil. So this CSF space gets effaced. So that's what you see on the axial here. And DTH में क्या हो जाएगा? यहाँ पे जो आपको cisterns दिखने थे, all of your basilar cisterns are all gone, right? So that's what you are seeing here, that the uncus is coming at the level of the brainstem, right? The schematic is really beautiful and, shows you what you will see on the CT. All right, so this is what you have to know. So just to summarize what you have to remember in your mind, we have learned first I see the scalp, right? You look for C-spine, you look for the face, you look for any air here, any metallic foreign body. After that, you start your brain window scrolling on the axial cuts, come from outside in, look at the scalp, look at the bones on bone recon better than bone window. Then what you're going to talk about are the different hematomas. So extra-axial injuries, they clear. Three things: EDH, STH, SH. Then you look at the intra-axial injuries, contusion, DAI, pneumocephalus, IVH, further inside. And then if there are any secondary injuries like herniation, ischemia, that is what you have to talk about. Central descending transtentorial Shubhangi is where the brainstem only comes down, right? So you have the brainstem herniating inferiorly through the transtentorium. So you'll see that there's a downward displacement of the brainstem. Pretty unusual, I haven't seen this myself, but this is what you are going to be seeing where the brainstem herniates inferiorly. Lateral DTH is far more common than central DTH, right? So now let me invite Dr. Ravi, who is going to talk about the neurosurgeons' point of view and what they actually want. And this is going to be very insightful because, even I don't know what they actually want and what is it that they are looking for in the reports and what matters. And it's really going to help you a lot in terms of your reporting. And when you get used to this kind of a clinical exposure at an earlier age, like in your radiology career, I think that's really going to shape up how you end up doing your reporting. So let me welcome him, and he will talk to you guys henceforth. So we'll just share his PDF also.
Good evening. So for the first time in last 3 years since Zainab has been teaching, so this is the first class I have attended along with you guys. So I realized that yes, my wife is a wonderful teacher. So I really think this class should be taught to all neurosurgery residents in AIMS and NIMAS because it was clicking the basics and it was very, very useful. So I'll touch the part. I hope my presentation is visible to all of you. So now Zainab has taught you almost all relevant theoretical parts. So I will touch the part which is uh, specific to what, as a faculty in AIMS, I will instruct my residents to ask the radiology SR. So usually the trauma setup is very busy setup. The patients keep on coming all day, all night, especially. And neurosurgery residents will keep pestering you, asking for some doubts. So, what are the doubts we usually ask for? Because that is what the faculty asks them on phone or in person or on rounds. So, they will pester you for that. So, to make you understand what they ask, what is relevant to them. So, that is what I will share. So this is my what I ask my residents practically on daily basis. This is what I have shared with you. So what as neurosurgeons we want your help. So don't think that neurosurgeons are just arrogant. We need a lot of help from radiology, and we need good radiologists. Definitely, the midline shift, as Zainab has taught you how to calculate with respect to the septum pellucidum, the line between the septum pellucidum and the falcine line. Now, usually, if we have a good resident, he is able to calculate the midline shift, because on whenever a patient resident is informing the faculty the case, he generally tells us what is the midline shift. So that is said like 9 mm, 10 mm. But we generally tell our residents to teach. But the most important thing is that many times people calculate the midline shift wrong. So now the you have uh, a vertical line which is um, so can you see the septum pellucidum? So this is the septum pellucidum, and this is the falcine line. Okay. Now the problem happens is that people sometimes miscalculate midline shift. You have to take the maximum diameter between these two lines, the maximum possible. It might sometimes there is bowing of the falls fox and bowing of the brain. So wherever you get the maximum reading, so what and in this section where you get the maximum reading, that is the midline shift. It is there is no one fixed section. It is gonna vary with every CT scan. So that is why we tell our residents to confirm with radiology SRs once again what is the maximum midline shift, especially in cases which are borderline, where you have to go by guideline where the midline shift is less. Obviously, if the patient, like in this case, has a very gross midline, which is we are expecting more than 10 mm, 15 mm midline shift, where you are not worried. But for cases where we have, so as someone has asked that at what level it should be calculated at the level where both lateral ventricle and upper part of the third ventricle is visible, and it should be actually calculated corresponding to the maximum level of compression. So you will have to scroll through a decent amount of section where you can see bilaterally lateral ventricles and where you can see the third ventricle. In all those sections where you get the maximum midline shift, that should be the answer to that question. Because sometimes the subdural hematoma or a collection or a intraparenchymal bleed is focal, and it is compressing sometimes inferiorly and sometimes superiorly. So you have to identify the level where, so the sections where in which you see the lateral ventricle and the third ventricle, all those level you check which is the maximum midline shift, the maximum horizontal shift between these two parallel lines, the septum pellucidum line and this, that will be your answer. So you'll have to might have to scroll about 4 or 5 millimeters at various levels and calculate the midline shift to identify which is an individualized level of maximum shift. So the second thing I ask my residents is that the midline shift is misleading. Many times midline shift is misleading, and this happens over years. What I've realized is that most radiology residents and neurosurgery residents also become too fixated with midline shifts. And trust me, if that is going to be the case, you're going to land up with a situation where you are going to end up losing a pediatric patient. First of all, for pediatric head injury, the brain is very, very robust. It is a very growing stage. So, and if you compare the CT head of an adult, especially an elderly patient, which has an atrophic brain versus a pediatric CT, if you are just banking on a midline shift or you are banking on a thickness of subdural hematoma, you are surely going to misinterpret, because most likely it might not correspond to the GCS of the patient. So, especially in pediatric patients, you should always look at the cisterns. All the cisterns which I've shown here, the suprasellar cistern, which is in the area where the optic nerves and the ICA are existing, the interpeduncular cistern, which is between the midbrain portions, the ambient cisterns, which are located laterally, and the crural cisterns, which are going to be located anteriorly, and the cortigeminal cisterns. All these cisterns, they are available at various different levels. So if you start scrolling from inferior to superior, so the inferior most section you will see the suprasellar cistern. Then you'll see the interpeduncular cistern, then you will see the crural cistern, then the ambient, and finally the quadrigeminal cistern. Honestly, in my clinical practice, the compression of cisterns has correlated to deterioration of patients much more than midline shifts. Sometimes midline shifts are misleading, especially when you have a thin SDH, but the brain is so full that if you have a SDH of 2 mm or 3 mm, still the patient will have a GCS of less than 9, and patient getting intubated with such a thin SDH because the brain is having a secondary brain injury. So seeing these cisterns, because, and especially what is the most overlooked cistern is the supracellular cistern, because, and this is the cistern which causes the maximum damage, which Zainab was telling, which we see the descending transtentoral herniation. When you have a descending transtentoral herniation, the usual cause is that you have a bilateral frontal hematoma and it occludes the cistern. And the moment this cistern gets occluded, you might lose the patient in a very short span of time, because now your entire inferior frontal lobe is going to compress either on the midbrain or on the hypothalamus. So sometimes you don't have to go by midline shift. Sometimes you won't have to go by the thickness of the SDH. You will have to go by the cisterns. So don't miss the cisterns. You report, let us suppose, if you report an SDH 1 mm less or more, that is not going to affect it. If you clearly mention that there is severe effacement of supracellular or interpeduncular cistern or the ambient cistern, that clearly indicates the surgeon that he needs to take this patient to OR. So that is what is more important than your midline shift values, which might be 0.5 or 1 mm here and there. That it doesn't really make a difference in practical life, though most trials are based on midline shifts only. Then is volume calculation. Now, this is the basic formula of a sphere, which is A into B into C divided by 2, where you calculate the length, the width, and the height. And the height generally we calculate in the coronal's recon. But if the coronal recon is not available and just have a sagittal, let us suppose axial, you measure the height by calculating the number of cuts which have encompassed. And let us suppose it takes 10 cuts and the cuts are of 5 mm each. So your height becomes 50 mm. So that is how you can calculate. And the volume is very, very essential, because this is what neurosurgeon will ask you. If it is an interplanetary hematoma, ki, sir, what is, or ma'am, what is the volume of this bleed? Because not that they cannot calculate, but generally people get lazy and they don't want to calculate and they want to call up the radiology SR at 2 o'clock in the night to for a, though I really advocate my residents to calculate on their own, but generally they call up the radiology SRs to ask that what is the volume of the bleed, because generally everyone is fixated on the fact that whether it is greater than or less than 30 ml. So this is will you have to practice calculating it. The next thing, what is the relevance of CT head? Why CT head is so important? Now, Zainab has told you the Canadian CT rule, the New Orleans rule. Now, in my practice, and we have an apex level trauma center in AIMS Delhi, which is the largest trauma center of this country, and Delhi itself has the largest morbidity and mortality of high speed road accidents. So I don't think so the head trauma which we are seeing is being seen anywhere in the country. For our practical purpose, any patient who comes with an impact, blunt trauma to the head and has headache, we by default get a CT head done. And for pediatric patients also, we get a CT head done, because as a protocol, any patient which comes, we have triaged the trauma center into red area, green area, and yellow area. Any patient who has headache, vomiting, comes to yellow area, or patient who is very sick goes to red area. Most all patients in yellow and red area, they undergo CT head. And as a protocol, we have made that we get a CT cervical spine done for all cases in AIMS Delhi, because there is a very, very high association between a cervical spine injury associated with a blunt trauma head. Especially, and if there's a penetrating injury, we definitely have to get a CT head. So for CT head in AIMS Delhi, we have a protocol that we get a CT head along with CTC spine plus whole spine screening. So this is done, almost being done for every patient, unless until patient is not at all symptomatic and has a very less dangerous mechanism of injury. For blanketly, we are following this because that helps to standardize our practice. So we get it done for everything. So on a daily basis, on a night of a trauma casualty, our SR stand up seeing a lot of CT heads. But what is the value of relevance of the prognostic value of the CT head? The prognostic value of CT head is based on these two scoring. Now, this was the old scoring, which is the Marshall scoring. It was called as the Marshall scoring. The latest is called as Rotterdam. So this actually shows what you need to look in a CT, because this is a prognostic scoring. The Rotterdam score, which is relevant at present world over, ranges from 0 to 5 on calculation, but you have to add +1 to it. So it ranges from 1 to 6. And from 1 to 6, the mortality increases from 10% to 60%. So let us suppose if someone has a Rotterdam score of 6, the chances of having a mortality is around 60%. Whereas someone has a Rotterdam score of 1 has a chance of mortality of 10%. Where you check the basal cisterns, all the basal cisterns which I have shown you, which is suprasellar cistern, interpeduncular, ambient, crural, and which you have to check whether they are compressed or whether they are absent. Then you check the midline shift, you check for epidural mass lesion, you check for IVH or SCH, and then you add up the score. So this actually is used by most neurosurgeons and being asked by from radiologists that what is the likely Rotterdam CT score of this patient, because that is an indirect prognostic marker to tell the relatives that yes, the chances of mortality are very high. So this is what, as protocol, most radiologists tell us after calculating. In many cases, Zainab had already taught you a growing skull fracture are the cases where we request the radiologist for a volume rendering technique, which is also called as the VRT. It is VRT because here you can see a growing skull fracture with the 3D recon, which is a volume rendering technique. Because so what do we mean by an epidural mass lesion in trauma? Anything which has a likely, why what to say epidural mass lesion, because we'll tell, because many a times we had a blended in a situation where we thought that this patient was actually an extradural hematoma, but we landed up with a tumor. So that is why we tend to use the term epidural mass lesion, because as protocol you might tend to have instead of an extradural hematoma, you might land up with a chronic Mets, or you might end up with a neuroblastoma also. So over time, we practice to use the term epidural mass lesion, which can be an hepatoma or can be another pathology also. So, but in most cases, 95% of the cases, it turns out to be an EDH only. Sometimes patients present to us with trivial trauma only, but accidentally. Now, hematomas will also be given as mass lesions in names, but oh, if there's an evident setting of trauma where there's a severe injury, you generally report it as extradural hematoma only. But if there is trivial trauma and you are not sure whether this is a mass lesion or EDH where a patient needs to get an MR done, then you report it as an epidural mass lesion. Because sometimes patient gives a history that patient went to a washroom and all of a sudden patient fell in washroom. Now you don't know whether patient suffered trauma in the washroom or just had a seizure or a syncope and fell down in washroom. Now in such cases, if a patient comes with, like we had a child who went to washroom, fell down, we don't know whether it was syncope, was presented to us to trauma center, the patient fell in the washroom. Now you don't know whether it's a seizure, whether it's a syncope, and what is relevant to that. So that is, in such cases, it turned out to be a neuroblastoma. So in such cases, you tend to use the term epidural mass lesion. Now the volume rendering technique is very useful because many radiologists suddenly ask us that why you need a VRT recon for this. Isn't it visible on the CT head, plain CT head? Why do you need a VRT section? The reason for that is you have to plan surgery on a VRT section. So that is why when you request a VRT recon, so that you can plan exactly based on sutures, what is the amount of craniotomy you need to reconstruct this growing skull fracture. So that is the relevance of getting a VRT, especially in the growing skull fracture. Then accessory injuries, very important, as I already told you. This patient who had a head injury with multiple tend to have occult spinal injuries. So like it has a hangman fracture here and it has a burst fracture of cervical spine. So as a protocol, we tend to do cervical spine CT and whole spine screening with head injury in all patients. And it might be a very associated orbital injuries, especially in patients like you can see here, where you can see a fragment which is compressing. In this case, it is compressing the optic canal. It is compressing the optic canal. So this compression of the optic canal causes the traumatic optic neuropathy. So this, you don't need to get a separate orbital CT for it. So in all cases, especially if the impact is closer to the frontal skull base, we ask our residents to confirm with the radiology SRs whether it has an associated optic injury or not, or whether in some cases you might have entrapment of the orbital muscle, which causes the restriction of eye movements. Like you can see, the inferior rectus muscle has been blown out to the orbital floor and it got entrapped, and that causes extraocular palsy. So these injuries, so you being as a radiologist, you have to visualize CT head in such a way that you are covering orbital and maxillofacial injuries to the maximum possible in the same, which Zainab will definitely cover as orbit and paranasal sinuses separately. And definitely, when you have skull-based fractures, we have anticipated CSF leaks. And many patients present with CSF leaks to trauma setup also, where we request the radiologist to get a CT cisterno done, which is a CT cisterno, as you can see the defect here. And or you might get a MR cisterno done in such cases. Then in for penetrating injury, we request the radiologist for either a DSA or a CT angio, especially for missile injury. You can see in this patient. And we need DSA, we need to see whether the major vessel like ICA, middle cerebral artery, are either involved or compressed or injured. And how is the cross flow? As in this case, we can checking the cross flow, whether the right side ICA is able to supply the contralateral side. The reason for that is, if this in now you have a penetrating injury on the left side, why we are checking the right side cross flow is that because while removing this foreign body from the eye as a neurosurgeon, we would like the radiologist to comment on the cross flow from the right side. So you have to remove the foreign body from the left side. When you will try to remove this foreign body, there's a very high chance that you will end up injuring the ICA on the left side. You might injure the ICA on the left side when you remove this foreign body, or you might have to go to the neck and coagulate or entrap this ICA. So for this, you need to be sure that what if I occlude the ICA on the right side, on the left side, whether the ICA which is patent on the right side is supplying to the contralateral side or not. So in this DSA, you can see that the run from the right side ICA is filling the ACA on the both sides, and it is even spilling over to the contralateral MCA. So this is very, very important where in penetrating head injury, where we need a digital suppression imaging as apart from the CT head also. Now, this is what is the nemesis of a neurosurgeon, which is called as quasi-bioma. Now, the problem is, as radiologists, someday you might end up in a situation where you have to report this. Because when you are operating on a brain, you might leave a cottonoid or a gauze piece behind. And it is like a foreign body, with huge peripheral edema, which is hypointense on T2 and has patchy peripheral enhancement. And most surgeons in such cases will disagree that they left the gauze behind, but in best case scenario, you should go back and re-explore such cases. And only histopathology can definitely prove whether it's a gaussipioma or not, or it can be just a foreign body infection also. So this is very, very important, and especially in trauma setting, one day or the other, you in your lifetime, you will encounter a situation where you'll feel a gauze piece in a patient who was previously operated in head injury, because in head injury, most neurosurgeons are operating in a very, very high stressful situation because patient is bleeding and you need to do surgery fast. So accidentally, you might left a cotton behind. So this is very, very important for medical legal purposes. Now, the biggest problem we face is that once you get a baseline CT, when you ask your resident to get a repeat CT, he will say, sir, I talked to the radiology resident and he's saying, what is the indication for a repeat CT? So because when an SR neurosurgery will call up a radiology SR, he will say, iska indication kya hai? What is the indication? Why I should get a repeat CT? Not that the radiology per se has to sit and do, a technician will also ask. So two setups which I feel needs repeat CT, almost 24 hours, repeat CT, is first is contusions. Temporal and frontal contusions, they evolve over time. And the patients with temporal and frontal contusions, they deteriorate from day 3 to day 7. They don't deteriorate on day 1. They don't deteriorate on day 2. They start deteriorating somewhere around 4 or 5 days because the venous edema increases. So you can see in this case how a thin contusion evolved into a condition where patient is developing a PC infarct and knee surgery. So in such cases, every 24 hours, we get a repeat CT. And that is why some neurosurgery SR might ask you that why you're getting, we need to get a repeat CT after 24 hours. The second thing is evolution of post-traumatic hydrocephalus. Especially if a patient has undergone decompressive cranectomy, you patient tend to develop in some cases, hydrocephalus, which is post. Now, the problem is you will think the patient has already undergone surgery. Why a neurosurgeon needs a fresh CT, and that too repeatedly. Sometimes patients start developing subgaleal collection. Now, this subgaleal collection is also a manifestation of external hydrocephalus. Because the ventricular system is not that compliant, the CSF starts accumulating in the subdural space where there is no bone, or it might form a subdural hygroma, or it might just cause the dilatation of the ventricle itself. All these forms, just ventricular dilatation is not the definition of hydrocephalus, especially in trauma setup and where a decompressive cranectomy has been done. A subgaleal collection, a subdural hygroma, or ventricular enlargement, all these are parts of the spectrum of post-traumatic hydrocephalus, which evolves over time, especially in patients who have SAH, patients who undergo bifrontal decompressive, patients who have IVH. They tend to develop these kinds of things, and in these cases, you will be requested to get a repeat CT done so that if a ventricular peritoneal shunt can be planned in such a case. And last slide, the tricky situations, which Zainab already discussed, whether it's EDH, whether it is SDH, whether it is both. In some cases, EDH versus SDH, conventionally you will be able to distinguish, but there might be cases where it might be both. You might have an EDH and SDH. So don't be too dogmatic. And I tell my SR also, don't be after a radiologist live to ask whether it's an EDH or an SDH. You just tell me what's the Rotterdam score. We will operate and we'll find out. Because in many cases where you have a large EDH, we always open the durameter and check whether it's an underlying SDH or not. So I think so. If you have doubt, you just stick to what your gut is, and the remaining the neurosurgeons can find out once they open it up. Very important thing is trivial trauma setting, especially in cases where in history, it's just a history of a trivial fall. Your suspicion whether there's a contusion or whether there's a tumor bleed should be very high. And we have faced these situations many a time that a patient came with a history of trivial fall, having a seizure, misdiagnosed as having a head injury, and eventually when the surgeon went to operate, instead of contusion, he realized it was a tumor bleed. Similarly, sometimes the patient presents with you with hypertensive bleed. A hypertensive bleed, elderly patient fell down. An AVM bleed fell down. So all these things are possible. But what are suggestive of this? First, there should be trivial trauma. Second, there is no underlying fracture. In such cases, there is no bony injury. Secondly, you can see there is only one focal hemorrhage. Especially in the setting of trauma, you see multiple small contusions with one big contusion, or there is effacement. Because in such cases, an elderly patient who has history of hypertension might have hypertension ICH. For vascular bleed, the location is generally not basal ganglia. Location is generally not poles. It is the lobar location, high parietal, medial temporal, or it is in the posterior temporal or in the vision area. So all these things which are not typical of a hypertensive or traumatic area, which are located deep, closer to ventricles, might suggest a AVM bleed, which might come to you accidentally as a trauma case. Then cases where you have child abuse, you have to be very, very careful in children, especially when you're reporting trauma. Very careful. Many times children are brought in India to hospital settings saying the child fell from bed, but actually, so look for the signs of child abuse and look for signs of adjacent injuries in various parts of the body. Now, posterior fossa injury sometimes can be very, very tricky for radiologists. The problem is because of what is called as beam hardening effect, which Zainab will discuss differently, because you have a posterior fossa, you have the petrous bone, you have the clivus, and all of a sudden you have the brain. So because of change in the densities from such a dense bone of the skull base to the brain, which is softer density, there is artifact, which is called as streaking artifact. And sometimes you miss bleeds in the posterior fossa. You miss the tonsillar herniation. So whenever you are scrolling through posterior fossa, be very slow, very careful, and see the tonsil impaction, because you might miss it because of the beam hardening effect, which is an artifact which is generally seen on CT head. The role of DTI, which Zainab was telling in diffuse axonal injury, is when you do not see anything on SWI and GRE. So let us suppose there's a patient where you got a CT head done, has history of trauma, and we had a patient from Korea who was working in India, who had a motor traffic accident, was driving a bicycle. He fell down. His GCS was 5, intubated. CT had done normal, completely normal CT had done. Then we ultimately got a MRI done, the GRE and SWI completely normal. But the patient's GCS is still 5. Why the patient's GCS is 5? And then we finally got a diffusion tensor imaging done. When we got the diffusion tensor imaging done, what we saw was in DTI, what Zainab will teach you in further lecture, something called as FA value. We call it fractional anisotropy. You see all the tracks, long tracks, and we realized that starting from corpus callosum to the internal capsule to the longitudinal fibers, all had decreased in the FA value. So these are the settings where DTI has relevance in diffuse axonal injury, where you are not able to rule out on conventional MRI sequences, and or in CT head, you get a DTI done. Though it does not have any prognostic, it does not have any relevance that we cannot treat it, but it definitely helps making a diagnosis and tells that, okay, we can counsel the patient that it is because of these long tracks that the patient is not waking up and there is retraction bulb injuries. So we can just manage the patient conservatively, because this helps to rule out metabolic causes. Because sometimes we think that patient has a metabolic issue or has an ongoing sepsis, that this patient is not recovering and has a poor GCS. But if you see on DTI decrease, so now that is what is the tricky. Now if the tracks are damaged, now for blooming, if there are hemorrhages, if sometimes you have non-hemorrhagic contusions. When you have non-hemorrhagic contusions, it will not show blooming on GRE. And especially in cases where you have non-hemorrhagic contusion and focal deficits to long tracks. In such cases, GRE and SWI might turn out to be non-conclusive. And such cases why the relevance of DTI comes. Okay. And pediatric head injury. My suggestion is the most careful CT scan you should ever read if you are getting a pediatric CT to report it. See it twice, see it thrice. I tell my resident to see it as many times as possible, because children are most tricky to treat. So this is very, very important, because the brain of the CT, in the CT head of a child, the brain is very grainy. It is very difficult to distinguish a subdural hematoma, the developing infarct. It is very grainy because it's very robust, it's very full. It is not like an adult brain. So be very careful. Change the window to subdural window, as Annabeth told you, and be very careful, especially looking at the cisterns in a pediatric head injury. So this is what me as a neurosurgeon would request all radiologists to follow in their setup. I'm sure the remaining you will learn as you practice along, because it's an everyday practice. So thank you so much for having me. I hope you enjoyed the class. The meaning Zainab can take over. Thank you so much.
All right, so thank you so much, guys. I think it's been a long class, but hopefully you all learned a lot out of it, and I think lots of insight. And this is how I would have learned to learn at residency level. Unfortunately, there was no such platform, but it's really great that you can see both of the aspects, right? So I hope you liked it, and looking forward to your feedback. You know, if you want this sort of an interaction to go on, and I think the classes may be long, but in the long run it will really help you. And now is the time to just invest these hours, and hopefully you will learn a lot out of it. So thank you so much, and thank you for the wishes, all of you guys. So I'll see you all soon. The next class is in a couple of days, so we'll get back to you on the schedule. Thank you so much, and I'll see you all on the other side. And we'll also have a lot of you have been asking for physics topics from ultrasound and MRI and CT, so those also I will do. And I my first priority now is to do the workstation, the live reading of the scans, right? So that a lot of you who are young residents in your first year can learn how to report scans, how to read scans. I think that is what I want to do first, and physics is more theory, so that I will keep recording as we go along. Okay. All right, thank you so much for your wishes. And I'll see you all soon. Thank you. Bye.